Congratulations for coming into the final round. Now we'll start off with the first candidate. Comparative study between magnocellular stimulation and occlusive therapy treatment in amblyopia. Grishma Marie.
Good morning. My topic is comparative study, magnocellular stimulation versus occlusion therapy, a prospective case control study in amblyopia treatment. Amblyopia is a developmental disorder of spatial vision affecting 2 to 5% of the global population. The current gold standard treatment for amblyopia is occlusion therapy, that is patching of the dominant eye to stimulate the amblyopic eye, where the success rates was found to be 50 to 75%. Major limitations of the current therapy includes treatment adherence, psychological impacts, and practical difficulties when amblyopic eye vision is reduced severely. Coming to the newer approach, that is magnocellular stimulation, Dr. Santan Gopal et al. He discovered an orthoptic magnocellular stimulator which showed an improvement of 64% improvement in visual acuity and 97% in stereo acuity, and the mechanism was based on magnocellular stimulation. And the principle behind the magnocellular stimulation was maximum foveal stimulation was seen during the initiation of saccades, which was studied from a series of 5 positron emission tomography experiments. Now coming to the parvocellular pathway, which is the major pathway for occlusion. When light falls on the fovea, the parvocellular ganglion cells gets activated and information is passed to the lateral geniculate body. And from there it reaches the 4C beta area of the primary visual cortex where the foveal stimulation occurs. And coming to the magnocellular pathway, which is the major pathway for the orthoptic device, here when the stimulus is transmitted at the fovea, the M ganglion cells transmits the information to the lateral geniculate body, that is 1 and 2 areas of the lateral geniculate nucleus. From there it again reaches the primary visual cortex area 4C alpha, which is further processed in the posterior parietal cortex. And also information from the frontal eye field and posterior parietal cortex again comes back to the primary visual cortex where the foveal stimulation occurs. Aim and objective: to study and compare improvement in visual acuity with magnocellular stimulator and occlusion therapy in the management of amblyopia. Secondary objective is to see the improvement in stereopsis. It was a hospital-based randomized prospective case control study. Patients diagnosed with amblyopia attending the pediatric ophthalmology clinic from May 2023 to November 2024 were included. Amblyopic children of age group 5 to 12 years, refractive amblyopia, strabismic amblyopia, and visual acuity less than 6 by 12 vision, and those not undergone occlusion therapy in the past 6 months were included, and those with defective vision due to trauma to eyes, deprivation amblyopia, and defective vision due to retinal and optic nerve pathologies were excluded from the study. Target population of 81, that is 41 in the occlusion and 40 in orthoptic groups of age group 5 to 12 years were taken for the study. Consecutive sampling done divided alternatively into both the groups. Snellen visual acuity values were recorded and converted to their corresponding logMAR values. Stereo acuity was measured using TNO test wearing red-green goggles and was graded. Now, occlusion therapy protocol based on the pediatric eye disease investigator group. 2 hours of daily patching was advised, which was monitored by parents. And magnocellular stimulation protocol, the orthoptic device protocol involves 30-minute structured 2 programs with LED light tracking exercises. And the 2 programs each consist of uniocular movement of 800 times and binocular movement 500 times. Total duration includes 7 months for a total of 17 sessions. And follow-up occurs at the end of 1st, 3rd, 5th, and 7th months for the parameters of best corrected visual acuity and stereo acuity. Now, 41 eyes in the occlusion group and 40 eyes in the orthoptic group with amblyopia of age group 5 to 12 years were included in the study, and the study was statistically analyzed by statistician. Assessment of change of best corrected visual acuity at different time points in the occlusion group showed that a significant and consistent improvement in visual acuity from baseline, and that of the orthoptic group also showed a significant and consistent improvement in visual acuity from baseline. When comparing the best corrected visual acuity between the two groups, at 1 month we saw that the orthoptic group showed a statistically significant improvement over the occlusion group. Beyond 1 month, both groups continued to improve, but the difference between them was not statistically significant. Now, change of stereo acuity from baseline at different time points in both groups showed that occlusion showed a gradual improvement in stereo acuity. Orthoptic group showed a more rapid and significant improvement in stereo acuity. Now, comparison between the stereo acuity between two groups showed that the improvement in stereo acuity observed in the orthoptic group was found to be statistically significant compared to the occlusion group. The study was done to compare the benefits of orthoptic magnocellular stimulation with occlusion therapy in children with amblyopia in the age group of 5 to 12 years. The percentage of children having improvement in visual acuity from our study showed that there was 87.8% improvement in visual acuity with the occlusion group and 85% with the orthoptic group. Now, the percentage of children having improvement in stereo acuity from our study showed that 77.5% improvement was seen with the orthoptic group and 29.3% improvement was seen with the occlusion group. Now, improvement in best corrected visual acuity at 1 month, the orthoptic group showed a statistically significant improvement over the occlusion group. But at 7 months, both the groups showed almost similar improvement, that is 87.8% in occlusion and 85% in orthoptic. Now, coming to stereo acuity, a substantial improvement in stereo acuity was found in the orthoptic group throughout the study, that is 77.5% for orthoptic and 29.3% for occlusion. The superior stereo acuity outcome in the orthoptic group is attributed to the binocular approach of the therapy and higher compliance as each session was done and monitored at hospital. The strength of the study was no other similar comparative study was available in literature and was able to monitor at hospital. Limitations of the study: difficulty to recruit children as they have to come to hospital daily for the sessions, and small sample size and follow-up time was limited. So conclusion, the improvement in visual acuity in orthoptic group was higher in the first month, though at the end of 7 months was almost similar in both the groups. Stereo acuity improved in both the groups, but the improvement seen in orthoptic group was significant, that is 77.5% when compared to occlusion group, which was 29.3%. So our recommendations are increasing the frequency of sessions in the orthoptic group over the last 4 months could have led to a better improvement. Longer follow-up is necessary to evaluate regression of vision after stopping the treatment. Thank you.
Good presentation. So you have 7 months follow-up.
Yes,
Are you
ma'am.
planning to further follow up the patients?
Yes, ma'am.
For how long?
Actually, my study protocol duration was limited, so we were not able to assess whether there was, after stopping the total 17 sessions were there. So after stopping the sessions, we were not able to. We didn't have time to look for the reduction in regression of the vision. So we are planning to improve
Further.
to
Follow the patients
call the
further.
patients back for follow-up, and so that initially our orthoptic device has a daily for the first weeks we had daily sessions, and then weekly ones, 2 weekly ones. Then after that we are having each session with a gap of 2-month interval. So in the study was shown that in the first period there was rapid improvement. So we are planning to incorporate more sessions in the final duration of the treatment also.
So that will benefit the
Yes.
patients.
Amblyopia is not one known. So there are various subgroups of amblyopia. So we should see each subgroup independently.
Yes,
Like
sir.
you can have 4 assorted groups,
Yes,
4 pure groups of different types of amblyopia, like Travis mechanism and like that, and then see whether how it works.
Okay, sir.
And the third group of both combined, both orthoptic and occlusion, that kind of one group should also be there.
Okay, sir.
Because we know that both are independently working
Yes.
and both are easily doable in a child of that segment. So you can as well add one group and
Yes.
prove that that works very effectively than the other pure
Okay, sir.
individual groups. Okay.
Okay, sir. Thank you, sir.
Move on to the next topic. May I call upon Dr. Sanju Shankar to talk on human ocular dirophyllariasis, emerging stenosis in eye and orbit.
Good morning. Discussing human ocular dirophyllariasis and emerging zoonosis in the eye. Myself, Dr. Sanju Shankar. Dirophyllariasis is an emerging zoonosis endemic to South Kerala, and it is really a concern, and that's the reason why I am here today with this topic. It is caused by nematodes of the genus Dirophyllaria, of which most common are Dirophyllaria repens and Dirophyllaria immitis, and it is being transmitted by the female mosquito vector. And this is a life cycle of the Dirophyllaria repens, which is known to cause the ocular lesions. Dogs are the reservoir host from where the infection is transmitted by a female mosquitoes to humans who are the dead end host. And in our area, there are various factors which are favoring the growth of the vector population, which include natural water sources, humid climates, rainfall, heat islands, and stray dogs. Aim of my study is to analyze demographics, identify varying clinical presentation, management approaches, and treatment outcomes. Mine was a retrospective study of 33 patients with ocular dirophilariasis conducted at a single tertiary eye care center in Kerala of 8 years duration, and all patients presenting with acute ocular inflammation associated with itching and radiologically confirmed with a cystic mass was included, while patients with loss follow-up being excluded. On analysis, out of the 33 patients, 55% were females and 45% males, and the age of presentation ranged from 2 years to 88 years with a median age of 46 years, and all patients had unilateral involvement. Coming to clinical presentation, the most commonest symptom was acute onset eyelid swelling along with itching with associated pain, and duration ranged from 2 weeks to 8 months. According to anatomical distribution, 55% had eyelid involvement, 39% with orbital involvement, and 6% with conjunctival involvement. On examination, the most common clinical sign elicited was a palpable mass in 78%, followed by lid edema, congestion, chemosis, proptosis, and preseptal cellulitis. The image in the right topmost is an image of a patient who presented with only a palpable mass without any signs of inflammation. And all those patients whom we had a clinical suspicion was sent for an imaging technique which included an ultrasound B scan, which as in the image demonstrated a cystic swelling with a serpiginous structure with parallel echogenic walls and an echoing lumen, giving a tram track appearance. An MRI orbit, T1 weighted MRI revealed a hyperintense well circumscribed rim with hypointense core, and T2 weighted MRI as in the image demonstrated a well encapsulated hyperintense lesion with a hypointense rim. And MRI assessed the plane of involvement and excluded other abnormalities. And all patients were given initially a medical management of tab prednisolone 1 milligram per kilogram body weight per day, tapered over 5 days, and tab albendazole 15 milligram per kilogram body weight in 2 divided doses, along with other symptomatic management. The treatment outcome, all the patients were initially given medical management, of which 85% had a complete cure and whom we had a sequential follow-up. Other 15% had an incomplete cure either due to persistence, progression, recurrence, or presence of a visible worm mass, for whom surgical management was indicated. Surgical management includes surgical excision, of which 60% underwent an eyelid lesion excision, 20% anterior orbitotomy plus lesion excision, and the rest 20% with a conjunctival lesion excision. And all patients whom we did a surgical excision, the specimen was sent for microbiology and histopathological analysis, which revealed a pseudocystic cavity surrounded by a fibrous capsule along with intense inflammatory cell infiltrate, and cavity contains sections of the nematode characterized by a thick multilayered cuticle as demonstrated in the image. The follow-up and cure rates, at the end of 1 month, 55% had complete cure, at the end of 2 months, 85%, and at 3 months, all patients had complete cure. And this is a case of a 2-year-old baby who was the youngest among our cases, who presented with a right-sided anterior orbital mass along with severe itching and proptosis for more than 6 months. She was referred from elsewhere. She was already on ivermectin and steroids, and on clinical suspicion, we sent her for a imaging as an MRI orbit, and a worm mass was detected in the superior rectus LPS complex. We did a anterior orbital exploration. The live worm along with the cyst was completely removed with preservation of the superior rectus and LPS muscle. So to conclude, Kerala is an endemic area for ocular dirophilariasis. It is a diagnostic challenge due to its varied clinical presentation. Clinical suspicion with imaging is a pointer to diagnosis. Treatment outcome is excellent with medical management. Surgical excision for persistent cases, and complete surgical removal offered negligible recurrence. So how to control? Strengthening awareness among clinicians. Public healthcare measures should be aimed at vector control, prevention of misdiagnosis, and control of stray dog population. These are my references. Thank you.
Do you have any patient who had manifestations elsewhere?
No, sir. Systemic manifestation was not there for all these 33 patients.
Okay. Your trial was only with albendazole. Did you try ivermectin?
No, sir. According to our hospital policy, we didn't start ivermectin for a single patient. We had good results. That is, all the patients had complete cure by 3 months. So we were trying with albendazole. And
How many days?
Sir, it was varying with different consultants, ranging from 1 week to 4 week duration.
All patients had systemic steroids?
Yes, sir. All patients we gave systemic steroids.
Is it mandatory?
Yes, sir, because the main pathology is the inflammation. So to control the inflammation, steroids are mandatory.
No, there are a lot of patients who don't have any symptoms. You just get a granuloma alone. in the near the lid margin and all. It is asymptomatic. You just remove it, it will be okay. A lot of patients don't have any other symptoms. You see a swelling there, clinically, if you have experience, you know it's a dirophilia, you do ultrasound B scan, it will show the verb. You take it out, you just give a course of ivermectin or albendazole.
Yes.
There is no need for
For
steroids.
visible worm masses, we directly went for the surgical excision.
It usually happens when the worm is dead and then it produces these toxic reactions. Then you cover with
Inflammation.
to cover the inflammation, you give steroids.
Okay, sir.
Have you seen the worm live in the anterior chamber or in the retina?
No, sir. In my study, I didn't see any patients, sir.
There are a lot of cases we have seen in the retina, in the macula. It's just
Yes,
like
sir.
moving and all.
Yes.
How do you manage if there is a worm in the macula?
So we can do a pars plana vitrectomy and retrieve the worm along with steroid coverage.
Okay.
Thank you, sir.
I think Dr. Dhanya has to go for another presentation, so she will be called to present the next case. Intraoperative OCT guided assessment in combined cataract and MI. Ankit, okay. Ankit, okay.
Good morning, all. My study is on intraoperative OCT for real-time assessment of structural changes in combined cataract and minimally invasive glaucoma surgery. IOCT is a non-invasive imaging technique that provides real-time, high-resolution cross-sectional view of the ocular tissues during surgery, giving dynamic feedback on tissue changes, helping guide surgical decision-making across anterior and posterior segment procedures. Early generation handheld systems gave a static off-axis imaging, and it required surgical pauses. This caused interruptions in the surgical workflow. The second generation microscope mounted systems eliminated instrument repositioning, but it still needed surgical pauses. The third generation models like the RTO 800 enabled real-time visualization with live B scans at 30 frames per second on a heads-up display, offering axial resolution up to 4 micrometers. This completely eliminated workflow interruptions. And the fourth generation models, they give a 4D volumetric real-time OCT enabled by SWEPSOS technology, which is particularly useful in complex retinal detachment repairs. Its applications range from corneal procedures, where it's used to visualize the different layers of the cornea or behind the grafts. In cataract surgery, it helps evaluate the corneal incision, evaluate the lens tilt, the anterior chamber structures, detect viscoelastics, and even the retrolenticular space. In retinal procedures, it's mainly used to assess the thoroughness of PRM and ILM peeling. And in glaucoma procedures, like trabeculectomy, where it can help assess the scleral incision depth and uniformity in bleb needling and suturing, and as we shall see ahead, in assisting mixed procedures. The landmark studies were the Pioneer and the Discover studies, both reinforcing its feasibility and its ability to influence surgical decision making across anterior and posterior segment procedures. Our case involved a 70-year-old female who presented with gradual onset loss of vision in 6 months in both eyes and elevated intraocular pressure in both eyes. Her best corrected visual acuity in the right eye was 612 and left eye was 618. Intraocular pressure by applanation was 16 and 18 mm mercury in right and left eye respectively. The lens showed an immature senile cataract of nuclear sclerosis grade 2 in both eyes, and fundus evaluation showed a cup disc ratio of 0.7 consistent with glaucomatous optic neuropathy in both eyes, and in left eye showed a grade 3 epiretinal membrane. On gonioscopic evaluation of both eyes showed non-uniform angles with superior and temporal oppositional closure, which was seen to be reversible on dynamic indentation opening up to scleral spur. She was on maximum medical anti-glaucoma medications at the time of presentation. She underwent combined procedures in the left eye, including phacoemulsification and IOL implantation, followed by vitrectomy with ERM peeling, and then mixed with KDB goniotomy under gonioscopy. The IOCT was integrated into the mix procedure. The IOCT findings during mix included being able to visualize de-roofed Schlemm's canal, confirming adequate trabecular meshwork removal, and also detecting a localized decimate stripping at the entry point of the goniotomy. This image shows the immediate preoperative scan of the left eye, showing the trabecular meshwork. This is done intraoperatively, showing the open angles, showing a de-roofed Schlemm's canal. This is the inadvertent decimate stripping at the entry point of goniotomy, which is again confirmed by the anterior segment OCT. Postoperatively, her best corrected visual acuity improved to 6.9. IOP reduced 30% on postoperative day 4 without the need of anti-glaucoma medications. Clinical implications: we were able to visualize the trabecular meshwork and Schlemm's canal anatomy and confirm adequate removal, detect micro complications intraoperatively, thereby enhancing surgeon confidence and patient safety. The IOCT that we used was the iScanner 7VN integrated IOCT, which is a lightweight portable OCT prototype. It was able to provide adequate imaging resolution for the anterior segment. Although it's not fully microscope integrated, so there are limitations regarding real-time visualization during tissue manipulation. So it is evident that there is a potential for real-time surgical guidance during mixed procedures. It improves surgical precision, reduces complications, and enhances outcomes in complex anterior segment procedures. Our case also reinforces the value of immediate post-operative imaging, and it could become a standard practice as the technology advances. Our limitations were that live KDB visualization was not possible. There is a learning curve for IOCT alignment, and a technician would usually be needed on standby. And our study lacked any objective measurable outcomes, so there is poor comparability, and also the cost and availability of the IOCT are limitations. To conclude, we carried out a successful application of IOCT for assessing KDB goniotomy completion in a complex anterior segment procedure. We were able to carry out on-table anatomical confirmation during mix, detect micro complications early on, and improve surgical precision and outcomes. While limitations exist with our model, fully integrated IOCT holds promise for enhancing safety, precision, and outcomes in mixed procedures. These are my references. Thank you.
Good presentation. Will everybody be able to follow this? How useful will this be to the patients and the society?
Mostly in cataract surgeries, there is a question of its feasibility, but in corneal and retinal procedures, it has been shown to make up for its worth in investment.
Value will be more when something guides us into a fine procedure.
Yeah.
Doing a procedure which also has visual, there is a chance that you can visualize that. Then trying to do an OCT post doing it and finding out whether it's pakka or not will not have much value, I think. Not in retinal layers, it will have value because we are going into layers that it has value. But in these procedures where you said, I'm not sure whether it has that much value. And more so in a clear media only OCT will work. So anything hazy, cornea hazy or something of that kind, then only an UBM can try to do these things. So an ultrasound guided Kahoot blade, which will exactly go and touch the exact place where you want, will be where we should go. Limiting ourselves to OCT guided, not guided, OCT validation of what you have already done, I'm not sure whether it's having that much value. What will you do? You see, post procedure, you'd see, and it's wrong. What will you do? Then you'll have to revise.
If we haven't closed the wound already,
Then you'll have to revise it.
Yeah.
So that way, we will be better off with a ultrasound guided correct procedure.
Will be Dr. Nafisatul Misria presenting on tactile revolution in eye drop management for the visually disabled.
So, good morning all. I would like to present our journey on tactile, which is a tactile marker on eye drop for patients with low vision. Imagine a visually impaired patient who has been prescribed with 3 different types of eye drops. The biggest challenge here is identifying which drop to use now, how many times a day, and how many drops. These patients always need someone assistant to administer their drops, make them more dependent on caregivers, losing their confidence, which may result in missed doses, medication errors, compromised recovery, and complications. And studies have documented cases of inadvertent use of both ophthalmic and non-ophthalmic medications, highlighting this as a significant issue. And many of our patients are struggling with the same issue, so there has to be a better way. Our question was, how can we create a practical and affordable solution to help visually impaired patients instill their eye drops independently? Our answer to this question is Tactile, which is a tactile or touch-based marker system on eye drop for patients with low vision. Tactile basically composed of a label embosser machine, which is available in various online platforms like Amazon and Flipkart for less than 1000 rupees. It is used to create raised numerical markings by pressing at a desired alphabet or number. And this label strip is refillable to the same embosser, make it more economical solution. And the embossed strip is one side sticky, is then attached to the eye drop bottle. And patient is trained to touch and feel the lines, and the number of vertical lines implies the number of times the eye drop should use. And instead of vertical line, we can press any number. For example, if we want our patient to put 2 drops at 4 times, we can press the number 2 at 4 times. And this is how we use it, the tactile system, making the embossed label marker by pressing at number 1, and after our desired dose, we cut the label by pressing on option marked as scissors, and it is attached to the eye drops. The whole process of tactile marking will take half a minute only, and hence it is very time consuming procedure. So for evaluating the impact of tactile, we conducted a study to compare the treatment adherence, patient satisfaction, and medication error rates between patients with standard eye drop application and tactile labeled eye drop application. Our intervention group consisted of 50 VR surgery patients who received tactile labeled eye drops, and control group consisted of same number of patients who uses usual eye drop bottle without tactile marking. And patients with cognitive disorder affecting touch are excluded from the study. It was a prospective questionnaire-based study conducted in a tertiary eye care center with a sample size of 100 post-operative VR surgery patients, and data collection was done within a period of 6 months. And patient is trained to use the tactile system within 1 to 2 minutes on the day of surgery. And patient feedback is taken by a structured questionnaire based on Likert scale at the end of 1 month when they are coming for their second post-operative visit. And questionnaire mainly consisted of 6 variables: whether they maintained correct dose and dosage, did they miss any doses, independent installation possible or not, how easy was it to instill their eye drops, how satisfied they are with their eye drops, and about the symptom improvement. These were the 6 variables I checked. And result shows that 84% in the tactile group were able to maintain correct dose and dosage against 60% in the control group. And there is less incidence of missed doses in the tactile group comparing to the control group. And 82% in the tactile group reported easy eye drop installation against 54% in the control group. And the most important good thing about tactile is 78% of them were able to manage their eye drops by themselves. And there is little difference in the symptom improvement, but tactile group was still better. And overall mean satisfaction score is 4.5 out of 5 in the tactile group against a 3.2 score in the control group. So tactile is a simple and cost-effective scalable tool which improved treatment adherence, hence less medication error cost. And it promoted self-installation and thereby reduced caregivers' load in post-operative VR surgery patients. We also noted that patients with worse visual acuity benefited more from tactile. So concluded as introduction of tactile markers on ophthalmic medication enhances patient safety, reduces medication error among visually impaired patients. It promotes independence and thereby boosts their confidence. It has potential for smart integration and is suitable for widespread clinical implementation. We hope it brings smile on their faces and thereby brightens their future. These are my references. Thank you.
Good presentation. I had the opportunity to see the same in poster podium also, and we were able to touch and feel it also. They had brought the samples. Yeah, that's a great innovation. It's a very simple one, practically possible, and it will really help the low vision patients. Very good.
We appreciate that because bringing self-care to these patients is very important because they are at home, all are left for work, so that's a big thing. And they have to go on with the drop for 6 weeks. But the issues are when it's going to taper, how will you do?
Yes.
When right eye has 4 times a day, left eye would have been already operated, will be 2 times a day. So how will you handle 2 different drops for both eyes, especially in glaucoma patients? They take X for right eye and Y drop for left eye. How will we manage? So these are some things we have to work upon. But otherwise, the principle, in principle, it's a very good.
For tapering, we have a solution, sir.
What do you do?
For example, if we want our patient to drop 4, 3, 2, 1 dose, we can first press four lines, 4 vertical lines, then a horizontal line, then 3 vertical lines, then a horizontal line, then 2 lines, then a horizontal line, and 1 line. For that.
And they will feel and go.
Yes, sir.
That will be very confusing. I'm not sure that will work.
I heard this presentation yesterday also by your guide, I
Yes.
think Prithvi.
Yes, sir.
Same one. Isn't it?
Prathi sir invented this, but I conducted this study with the post-operative.
You conducted the study.
Yes.
Very good. We'll move on to the next talk by Dr. Pooja. Analysis of OCT RNFL thickness.
Our study is on the topic analysis of OCT RNFL and minimum rim width in myopic tilted disc and suspicious cup. Myopia can cause structural changes in eyes which make them more susceptible to axonal loss and can cause glaucomatous changes. And tilted disc can cause alterations in RNFL peak locations and can cause changes in macular ganglion cell complex distribution. RNFL thickness assessment is an important tool in evaluation and monitoring of glaucoma. However, in eyes with anatomical and structural variations like myopic tilted disc, it can lead to erroneous results. Spectralis OCT GMP edition has a new objective method of optic nerve head analysis, that is Brooks membrane opening minimum rim width assessment. Minimum rim width is the shortest distance between Brooks membrane opening and internal limiting membrane, which measures NRR perpendicular to the overlying rim tissue. Our aim is to analyze and correlate RNFL thickness and BMO MRW and to correlate visual field changes. There is a prospective cross-sectional study conducted in a tertiary hospital in 60 eyes with myopic tilted disc and suspicious cup over a period of 1 year. All patients underwent complete ophthalmic evaluations including refraction, optic nerve head evaluation, ovality index assessment, visual field analysis, OCT RNFL thickness and BMO MRW analysis. RNFL thickness and BMO MRW measurements were topographically compared at the level of hemidisc. Superior sectors are involved in the superior hemidisc and inferior sectors are included in the inferior hemidisc. A hemidisc is considered abnormal if either or both of 2 superior or inferior sectors was yellow or red. And if both RNFL and BMO are normal or both RNFL and BMO are abnormal, they are considered to have topographical agreement. Otherwise, they are considered to disagree with each other, and those cases underwent post hoc analysis. Inclusion criteria: age group between 20 to 60 years, best corrected visual acuity more than 6/18, and a refractive error up to -6 diopters without synergy correction up to -3 diopters. Exclusion criteria: any non-case of glaucoma patients, any patients with retinal pathologies, and those who underwent ocular surgeries. Our results: 45% were females, whereas 55% were males. 55% had moderate myopes, whereas 45% had mild myopia. The average RNFL thickness was higher in the inferior hemidisc. The average BMO MRW was also higher in the inferior hemidisc. Coming to agreement between RNFL thickness and BMO MRW, out of 120 hemidisc, 106 hemidisc showed agreement, whereas 14.16 only showed disagreement, that is 14 hemidisc showed disagreement. In mild myopia also there was good agreement, 19.7% showed agreement. In moderate myopia also 87.17% showed agreement. Out of 60 eyes, 45 patients had normal visual fields, whereas 15 showed visual field defects not meeting all of Anderson's criteria. The 14 hemidiscs which showed an disagreement underwent post hoc analysis done by 2 glaucoma consultants, and the number of false positive plus false negative for MRW was higher than that of RNFL, that is not statistically significant. The causes for disagreement were missed local defects, peripapillary atrophy, and shifting of RNFL peak. In our study done in myopic tilted disc and suspicious cup, 85.83% agreed, whereas 14.16% disagreed, and the cause for disagreement was missed local defect, shifting of RNFL peak, and peripapillary atrophy. A similar study done by Sola-Bruna et al. In early glaucoma group, 73.9% agreed, whereas 26.1% showed disagreement, and the causes were borderline significance level, local defects, and aberrant blood vessels. A study done by Robodella et al. In myopic this showed that BMO had an overall higher specificity than RNFL. Conclusion: the number of false positive plus false negative for BMO MRW was non-significantly higher than that of RNFL, and the BMO MRW and RNFL measures agreed in majority of hemidisc, and they disagreed in only 14.16%. So those cases who show disagreement should be followed up regularly, and we can include GCG analysis also to detect glaucomatous changes in pre-perimetric glaucoma. These are my references. Thank you.
Good presentation. A small comment. Please try to avoid abbreviations and this BMO, MRW, what you're saying, maybe you have told initially the expansion of it. In between also, you can tell once or twice so that if somebody had missed out in the early slides, they can follow our unit who is coming. So because that is a new thing, I have not heard before. RNFL, everybody knows, I think. So that's a general comment. And again, the same question as I asked for the previous speaker. What is the clinical implication of this? How will this benefit the patients? So if you do any study, there should be some benefit to the patients.
Nowadays, it has been told that BMO MRW is a better
Now also
modality.
you can expand and tell.
Okay, Brooks membrane opening minimum limit assessment is a better modality, but we did it in myopic tilted disc patients, and we came to a conclusion that in majority it agreed, only in very few cases it disagreed. So there is no need. We can say that we can when there is a disagreement, we should come to a conclusion that is after clinical examination, field studies, RNFL, BMO, everything should be put together, and we should come into a conclusion for how to follow up, manage, and diagnose patients in that cases. Because in our study, BMO is not a better modality as compared to RNFL. So if at all we can do a better BMO is available, we can go for BMO and RNFL and compare both, and then come to a conclusion.
Whether glaucoma is coexisting or not is a challenge. Yeah? That is your cohort. In that cohort, already RNFL thickness itself is an easily discernible value, but we still have doubts whether this is because high myopia. You are bringing in yet another variable which also has the same variability. I'm not sure. Just because you bring that Brooks membrane diameter, I don't think you will suddenly get a clinching diagnosis that this is Pakka glaucoma or something like that, unless you have functional corroboration. So this is again a structural looking at the disc with OCT. So probably this, whether it translates heavily on the field is to be seen. I don't think people will adapt to yet another variable, which also is yet another previous again.
Thank you. We'll move on to the next talk. We'll call on Safira. Sorry, Safira is presented? No. Safira will be talking on cataract screening.
Good morning all. Today I would like to share my study on cataract screening, validation of portable cystoscope for graded nuclear sclerosis in outreach scans. Cataracts remains the leading cause of avoidable blindness worldwide. The lens opacity classification system 3 performed on a slit lamp biomicroscope is the gold standard for grading cataract. The early detection and accurate grading of nuclear sclerosis are crucial for planning surgical intervention. And this is the lens opacity classification system 3 for grading nuclear cataract, cortical cataract, and posterior subcapsular cataract. The nuclear sclerosis is graded based on the color and opalences. The importance of grading nuclear sclerosis are pre-operative planning to plan the surgical technique and anticipate complication in surgical defect T, denser the nucleus, higher the phacoemulsification energy required. In IOL power calculation, dense nucleus affect the biometry due to poor fixation and in visual prognosis, aiding counseling about expected outcome. We know that slit lamp is the right hand of an ophthalmic surgeon and it is a gold standard device. The advantages of slit lamp are it helps in detailed visualization, has high magnification and slit illumination, and has binocular view and versatile. It can be combined with fundus lens, tonometers, etc. The disadvantages are it is bulky, electricity is needed, non-portable, and a trained personnel is required, high cost, and cannot examine in bedridden or immobile patients. In outreach camp, till now, cataract screening was done by diffuse beam of torchlight. The advantages of it are simple and quick, portable, rapid assessment can be done at anywhere. It is an initial triage tool to triage red eye, pupil reflex, etc. The disadvantages of it are gives only limited detail, no magnification, and no stereopsis. Here the problem is, while torchlight lacks strict illumination and optical sectioning, leading to limited diagnostic accuracy, on the other hand, slit lamp is bulky, non-portable, and requires skilled handling, making it less feasible in emergency or bedside setting and impractical in community outreach camp. To address this problem, we have introduced a new device called Scope, which is combines the advantages of both modalities and minimizes the drawback, which is a portable, user-friendly, compact, and cost-effective device which replicates the slit lamp-based cataract grading. This is the first model we made here. A black chart paper with the required size slit is stuck to the moonlight torch. Then a 4 into 1.5 centimeter black chart paper with a hole and IOL is glued to it. Then this chart paper with IOL is glued to the PVC pipe. Then the PVC pipe is fixed to the moonlight torch. This is a simple method and everyone can try this method. This is the 3D printed model of scope. The image showing design of the 3D printed scope, then slit end of the scope, third is the IOL end of the scope, then the final 3D printed scope adapter on the torch. Scope fabrication of the 3D printed model. For 3D printing, the sketch of the cylinder is incorporated into computer-aided design software with appropriate dimension, and the software exports this model native file format into standard triangle language file, which was used for 3D printing. Then this file was then converted into machine language, that is G code. Then this G code is then sent to 3D printer by Wi-Fi, which gets it to create the scope. It is printed using polylactic acid. This is the final scope. One end showing a 20 diopter IOL which converges the divergent light. The other showing the slit which reduces the aperture of torchlight. Then it is attached to moonlight torch to create the slit beam. This is the final scope. Then it is set and ready to use. This is how the examination by torchlight. We can see a diffuse light. This is how the examination by scope looks like. This is nuclear sclerosis grading in a patient showing grade 2 cataract examined by scope. This is in another patient showing nuclear sclerosis grade 3, and this is various examination finding by scope. To evaluate the diagnostic accuracy of this instrument, we conducted a study. The aim of our study was to assess the diagnostic accuracy of scope, examine nuclear sclerosis and compare with slit lamp LOCS grade 3, and to evaluate the reliability and ease of use. We conducted a prospective cross-sectional diagnostic validation study in patients attending a tertiary care center in North Kerala. The 100 participants, 200 eyes aged more than or equal to 50 years. The data is collected by systematic random sampling in 6 months from March 2025 to August 2025. The inclusion criteria: age more than or equal to 50 years, visual complaint suggestive of cataract, ability to fixate and cooperate during examination. And these are my exclusion criteria. Each underwent visual acuity testing, both unaided and bus-corrected visual acuity is tested. After mydriasis, then scope grading was done by an ophthalmologist and noted. Then standard slit lamp LOCS grading was done by another consultant, and it is noted more than 5 years of experience. The findings from both instruments were compared. Coming to result: age distribution 50 to 80 with an average age of 64. Gender distribution: male and female shows equal ratio, approximately 1:1. This is a graph showing comparison of scope versus slit lamp grading and showing similar grades from both instruments. This is the diagnostic performance chart showing sensitivity and specificity more than 90% and the diagnostic accuracy 93%, showing an excellent agreement. These are the advantages of scope. The scope offers key benefits: that it is portable, less expensive, time efficient, accurate for nuclear sclerosis grading, and can screen bedridden or immobile patient. Coming to conclusion, scope is a reliable, accurate, and user-friendly device suitable for community screening, and it bridges the gap between urban tertiary healthcare and rural healthcare and help in constructive counseling and patient care, and also aid in early detection of cataract and timely referral. And I hope if validated, this tool can the revolution is cataract detection in rural India. These are my references. Thank you.
Good presentation. Can you please go back to the methodology? Is it possible? You can tell who did this.
Actually, my mentor invented this and I conducted the study.
No. The slit scope usage was done by who used the slit scope? Is it ophthalmologist?
Consultant, yeah, with a 5-year
Can you please-
experience to ensure the accuracy,
Okay.
reliability, and to minimize inter-observer bias.
Okay. The same doctor, they did the slit lamp examination also for the patient.
No, another doctor.
It was done by another doctor,
Yes,
not the same person.
not the same person.
Do you have any video of the examination? Because it's a study and you have invented a new instrument. Do you have any video?
I
No.
brought it, the instrument, and
You have the
these are
instrument
the
with you. Oh.
Images.
And I have a lot of doubts in this. Actually, it is a very good instrument. It is going to be very useful for the outreach camps and all. This can be used by an optometrist also, not only by an ophthalmologist. It will be useful for the optometrist also, and in the vision centers also it can be used. But again, how is the grading validated? Like, do they compare every case with that LOCS grading?
We use LOCS grade 3 because it is international and
What will be the cost of this equipment once you make it?
it cost only about 350. The adapter cost only 350.
Do you get an optical section of the lens?
Yes, we get the optical section,
So
and any type of cataract can be examined.
So if you can get
And
an
also-
optical section of the lens, can you get an optical section of the cornea also?
Yes, we get.
Have you tried that?
Yes. Also, one of the major advantages of it is it can also examine the anterior chamber depth. So we have a plan to conduct a study to screen for angle closure glaucoma based on the limbal anterior chamber depth.
Do you think this can replace your slit lamp microscope?
Uh,
The way you are telling
cannot
optical
replace,
section, you can
but
take.
it is a complement.
No, if it's an instrument which can get the optical section of the cornea, the anterior chamber depth, and the optical section of the lens, and comparable with the results of slit lamp, it costing only 350 rupees, you can ask for a
Yes.
patent and
Can
go on a
replace
large scale and make it.
It is better tool for screening in outreach camps.
Actually, nowadays there is no need for grading at all. Everybody who sees a lens, they remove it. There is no need for lens opacity at all.
It will be helpful in that immobile patients who cannot attend the hospital regular visit. So,
Anyway, it's a novel idea, very good.
thank you, sir.
Good. It will really work in the field. You are creating a very good invention which is like very relevant. Only thing, as it was pointed out, that learning curve will be there. Whether you'll have to hold it obliquely, whether you'll have to hold it coaxially, we aren't sure. We aren't sure. Point number one. Point number two, why you are restricting to only nuclear sclerosis, I'm not sure. Even a posterior subcapsular should pick up. If
Yes,
what you are saying is
yes.
true. Even a PCU on the other eye, it should pick
Yes.
up.
It can
Argumentative.
detect all type of cataract.
So in
anterior
a field
chamber
case
from
where
the
one eye
lens.
has cataract, other eye is already operated 2 years, 3 years back, a PCU on the other eye also, it should pick up.
Yes, sir.
And more than that, the magnification factor and the comfort factors which a slit lamp gives, this cannot give. So this will not you are not planning to replace a slit lamp.
Yes.
So don't go in that angle.
Yes.
Try to complement
Yes,
just a
complement.
torchlight, oblique illumination with the torchlight with a more validated approach where more clear notes are given about the type of the cataract and the grade of the cataract. We are in the base hospital approach only. There is no camp surgeries anymore. No, all these patients go to the base hospital and they are getting evaluated again there, and then they are getting operated. So in that you are only validating that process. You are making it very pakka. You are no vagariness is coming inside. Very good. Try to work on this and also work on the cortical components of either other than just NS1, NS2, NS3, NS4.
Yes.
Okay.
Thank
Is
you,
it
sir.
battery operated or chargeable?
The Moonlight torch contain battery. That only the torch contain battery. It is not battery operated. The
Can you
adapter.
show us?
Yes.
Can you show us the slit scope?
Ready? Dr. Parakal. Presenting on clinical pathological patterns and surgical outcomes in periocular basal cell carcinoma.
Good morning. My study is titled Clinicopathological Patterns and Surgical Outcomes in Periocular Basal Cell Carcinoma, a retrospective study. Basal cell carcinoma is the most common malignant eyelid tumor worldwide, and BCC, a slow-growing tumor, rarely metastasized, but if left untreated, can invade local tissues, and wide surgical excision with intraoperative margin clearance remains the primary treatment. Here is a clinical picture showing a firm nodular lesion measuring 5 mm into 2 mm on the left upper lid, and the lesion has rolled edges, focal crusting. There is distortion of the eyelid margin and loss of lashes, which is highly suspicious of basal cell carcinoma. The aim of my study is to analyze the clinical pattern, pathological subtypes, and management outcomes in patients with periocular basal cell carcinoma for better understanding and management of basal cell carcinoma. It's a retrospective observational study carried out from 2014 to 2025, and we have included all patients who were histopathologically diagnosed with periocular basal cell carcinoma with complete clinical and histopathological documentation. These were the data collected. Moving on to the results, we had 17 number of patients who were histopathologically diagnosed with basal cell carcinoma with a mean duration of symptom of 3.22 years with a maximum follow-up period of 120 months and a mean period of follow-up of 49.12 months. The mean age of at presentation was 68.12 years, and there were no cases below the age of 40 years. In our study, there was a slight male predominance. At presentation, out of the 17 patients, 15 patients had primary lesion and 2 patients presented with recurrent lesions. Majority of the tumor measured less than 10 mm, and the mean tumor dimension was 8.79 mm. Among the 17 patients analyzed, 100% of the patients had loss of lashes, 59% had surface telangiectasia, 82% had rolled edges, 94% had central ulceration. Lower lid was the most common anatomical site involved. Nodular type was the most common histopathological variant, and all the lesions in a study were pigmented basal cell carcinoma. Local invasion was seen in 4 out of the 17 patients, of which 1 patient exhibited perineural invasion. Direct closure was possible in 23% of the patients, but larger defects required flaps in 41%, grafts in 18%, and combined flaps plus graft in 18%. Lower eyelid involvement was most commonly seen in females and upper lid in males, but this was not statistically significant. Nodular BCC was predominantly seen in male, but was not statistically significant, and nodular BCC was commonly seen in lower eyelid and medial canthus, which was also not statistically significant. This is the case of a 53-year-old female status post wide excision and rotational flap reconstruction in 2022, now had presented with progressive increase in size of lesion. The first image shows a pre-operative picture showing a lesion in the medial canthus of the left eye with central ulceration and raised pearly edges, which is characteristic of rodent ulcer. And the second image shows intraoperative picture showing excised BCC with 4 mm clearance of margin with intraoperative frozen session, and the resulting full thickness defect was reconstructed with local cutaneous flaps and transconjunctival flap. And the third image is the post-operative image of the patient at 2 months follow-up. It shows a well-positioned flap. There is no flap congestion and necrosis. No recurrence at 9 months follow-up was noted. Moving on to discussion, the mean age of presentation was 68.1 year, shows increased incidence with advancing age. No cases below 40 years, which was consistent with the age-related risk pattern. The average duration of symptoms before presentation was 3.22 years, which shows a delay in seeking medical care among patients, and late presenters were 76.47%, who attended the clinic after 6 months after symptom onset. Lower eyelid was most common site. It can be due to greater UV exposure. 11.76% did not demonstrate the classical clinical features, and the most common histopathological type was nodular subtype, which was in line with other studies. All cases were pigmented BCC reflecting higher prevalence in darker skin tone. Local invasion occurred in 4, of which one case showed perineural invasion, which is a rare but important indicator of aggressive BCC. Direct closure was limited to small defects, whereas larger periocular BCC mainly required flaps, grafts, and flap plus graft, which was in line with other literatures reporting flaps as the predominant reconstructive method. There was no significant association between sex, tumor site, or histopathological subtype, and recurrence was observed only in previously treated cases, which can be linked to incomplete excision. Complete tumor excision with 4 mm margin clearance with intraoperative frozen section achieved nil recurrence with a maximum follow-up period of 120 months and an average follow-up of 49.12 months. Our observation reveals that most evidence on periocular basal cell carcinoma comes from Western population, while Indian cases demonstrate differing trends. These population-specific differences highlight the necessity for detailed Indian studies to strengthen early detection, surgical planning, and recurrence prevention. The conclusion from my study is that basal cell carcinoma in eyelids can present even without classical clinical features, and hence suspicious lesions need meticulous follow-up and biopsy to confirm the diagnosis, and good functional outcome and disease-free survival is possible with appropriate surgical techniques and reconstruction. These are my references.
Any case had a resurgery? Any of these cases had a resurgery? You are seeing?
Sir, 2 cases were recurrent cases when they presented to us, and then we did resurgery, sir, and with follow-up period, none of the patients had recurrence again.
Okay. When you say like clinicopathologic patterns and surgical outcomes, it's a wide area. So we expect at least 20 tables. Like, those tables are not there. More nuanced looking into all the variables, all the subtypes, all that has to be done. And over time only, then you will know whether there is any recurrence, whether these flaps fail and become bad. All that also needs a continuation of the study and a wider patient selection. Okay.
How about the survival of this patient?
All the 17 patients are still surviving. Previous radiation therapy can predispose the patient to basal cell carcinoma. Yes, sir. No. Surgical excision is the primary treatment.
From the preventive aspect, do you like to say something? How to prevent this? Do you like to say something? Because you have done an extensive study regarding this.
Yes, ma'am. Increased ultraviolet light exposure, arsenic exposure, then immunosuppression predisposes to basal cell carcinoma. So we avoid.
Good presentation.
So the last presentation is by Jasmine on proportion of dyslipidemia in patients with meibomian gland dysfunction.
Good morning all, respected judges. Presenting my study on topic, proportion on dyslipidemia in patients with meibomian gland dysfunction in a tertiary care center. Meibomian gland dysfunction is one of the most common ocular surface disorder and a major contributor to evaporative dry eye disease. Changes in systemic lipid metabolism may alter meibum composition, increases its viscosity, and raising the melting point, thereby leading to glandular obstruction and progression of MGD. Understanding the relationship between both may help in identifying dyslipidemia as a modifiable risk factor for MGD and provide new insight into preventive and therapeutic strategies. Screening for dyslipidemia in patients diagnosed with MGD allows for early detection and intervention, potentially improving both systemic and ocular health outcomes. The primary aim of my study is to estimate the proportion of dyslipidemia in patients presenting with meibomian gland dysfunction in OPD, and secondary objectives were to determine the association between MGD and individual parameters of fasting lipid profile, to assess the effect of dyslipidemia on severity of MGD, to identify whether treating dyslipidemia causes improvement in MGD. The study population include patients of age group 45 to 75 years attending OPD And the study design was a cross-sectional analytical study with convenient sampling of duration 1.5 years with sample size of 50 patients. And the inclusion criteria include all patients presenting with MGD and not on any lipid lowering agent. Exclusion criteria were patient using medications which cause dry eye like tricyclic antidepressants, antihistamines, diuretics, beta blockers, patients on anti-glaucoma medications, patients with rheumatoid arthritis, Sjogren's, lupus, and patients with history of previous ocular trauma and ocular surgeries. Study variables were age distribution, gender distribution, slit lamp examination and staging of MGD, shimmer test, tear film breakup time test, fasting lipid profile including all individual parameters, and post-treatment improvement in symptoms. Coming to result, comparing age and clinical stages of MGD, higher number of MGD cases were seen between 60 to 70 years of age group, but the relation was not statistically significant, but age remained as a background risk factor, but does not independently determine disease severity in this data. Comparing gender and MGD severity, both genders were affected similarly across all clinical stages, but gender was not an independent factor influencing the severity of MGD. Comparing the total cholesterol level and severity of MGD, 64% of the participants had high level of total cholesterol, suggesting that most of the participants in this research had elevated cholesterol, which may be linked to severity of MGD. And a statistically significant association was found between total cholesterol level and severity of MGD. As the total cholesterol level increased, MGD severity also progressed with all stage 4 MGD patients having high cholesterol levels. Comparing LDL and MGD severity, 58% of our participants had high LDL level, indicating a significant proportion of the study population had elevated LDL cholesterol, but the p-value was suggest a borderline statistical significance. Maybe larger sample size may show stronger significance. Comparing triglyceride and MGD, 76% of participants had normal triglyceride level and the data was not statistically significant. HDL and VLDL also showed no statistical significant correlation with the study. Comparing the tear film breakup time, it was abnormal in all study participants, including tear film instability across all MGD stages, and the shimmer test also showed a decline in its value with increasing MGD severity. Conclusion, the study demonstrated a high prevalence of dyslipidemia among patients with meibomian gland dysfunction with total cholesterol showing statistically significant association with increasing MGD severity. Elevated LDL level also showed borderline relationship, whereas triglycerides, HDL and VLDL do not correlate with severity. Age and gender were not significant contributors. Hence, my study suggests that systemic lipid abnormalities, particularly hypercholesteremia, play an important role in pathogenesis and progression of MGD. Therefore, routine lipid profile screening in MGD patient is recommended as early detection and management of dyslipidemia may help improve both ocular surface health and overall systemic outcome. Further, longitudinal studies are needed to establish causality and assess the benefit of lipid lowering therapy in MGD management. The limitations of my study were small sample size, the cross-sectional study design, and a single standard study which may introduce selection bias and limitation of applicability to broader population. And the diagnosis and staging of MGD were based on clinical examination rather than advanced imaging techniques like meibomography. And the duration of follow-up was very short. And the study did not evaluate long-term effect of lipid profile management on MGD. Since the study duration was limited, it was difficult to study the effect of lipid lowering agent on reducing severity of MGD. These are my references. Thank you.
This is a good idea and it's a good thought process. But how will you explain the pathogenesis? How hyperlipidemia or dyslipidemia causes meibomian dysfunction?
Madam, meibum contains cholesterol esters, triglycerides, lipoproteins, etc. So, if there is increase in systemic lipids, it can alter the lipid. Meibomian glands are also lipid synthesizing organs, so it can alter the lipid composition of meibum. So, if there are increase in cholesterol esters, there will be increase in viscosity and the melting point of meibum will get elevated. So, there will be clogging of glands. But if LDL are elevated, it have more inflammation to the gland. If triglycerides also affect the metabolism of lipids. So, individual parameters affect differently. So, if we are
Different
comparing
mechanism.
the individual parameters, the treatment can be more specific and we can consider more than an ocular condition, we can consider it as a systemic condition. So, we can correct the systemic profiles also. So, it will be more benefit for the patient. Usually, MGDs are very difficult to treat, especially in older age group.
Yes, every second patient we see in the OPD has MGD. Every third patient has got dyslipidemia. So that's what how to correlate. Okay.
Denise, every fifth patient in the OPD also is on statins. So statins have become universal today. So that is that is a confusion whether that lipids have an just a relation with this, whether it's just a relation or it's a causality as you stated in
With
your
advanced technique,
in
we
your
can identify that
yeah.
we
So
need
that causality once you establish, then you will have strong base to say that this is this, and then you can say like LDL is this, HDL is this, that kind of looking into the deeper aspects of lipids.
if we have the facility to identify the individual parameters like mebum LDL, mebum cholesterol level, and if we are able to correlate it with the systemic cholesterol
Correct.
levels,
Correct.
it will be more. But biochemistry did not have that facility for
Correct.
that.
And you'll also need to say that once with the lipids getting controlled by medications in the systemic side, this MGD also comes down. That kind of relationship also you have to establish.
A lot of patients with MGD with lipid profile being completely normal. So you cannot blame this that this is the one cause for MGD. Just like we are telling ARCUS, juvenile ARCUS, it is due to lipid profile defect.
One
So,
cause among multiple factors.
yeah, maybe a predisposition. We like to correlate. Okay, thank you. All the candidates have performed very well, isn't it, sir?